Hello everyone, my name is Yu Chen. I'm assistant professor at Vanderbilt University Medical Center. Today I'm going to introduce our recent work to measure associations between perioperative collaboration structures and patient safety categorized by non-routine events. So what is the definition of non-routine events? Non-routine events are built based on optimal or expected care processes. If there is a deviation from a care process to its expected one, then the divided care process will be considered as a non-routine event. So non-routine event can cause unusual events, unsafe conditions, or adverse events. Unsafe events may not be the bad thing, maybe the good thing, right? And unsafe conditions can precursor to adverse events. Adverse events can potentially cause patient harm. Here are some examples of non-routine events collected from perioperative neonatal care. Non-routine events can occur during handover and other scenarios in the NICU. For instance, the team didn't include a registered nurse in the handover. This can be a non-routine event. And another example is neonatal intensive care unit attending left the handover before it started because another patient was having seizures and this attending was needed at the bedside. AHRQ created a patient safety network. Users can report adverse events through such a network. However, unusual events and unsafe conditions are underreported. Even adverse events are underreported. To promote comprehensive patient safety research, non-routine event reporting has been becoming more and more important because most of non-routine events are precursor of adverse events, and the identification and prevention of non-routine events, which may lead to adverse events, can significantly improve patient safety. Non-routine events can frequently occur in high-risk scenarios, such as perioperative neonatal care. Non-routine event reporting can be affected by various factors, including human, team, and organization environment. We assume perioperative care structure can impact non-routine event reporting behavior of a clinician who is affiliated with the structure. We investigated 26 months of non-routine event data and electronic health record data. All non-routine events were voluntarily reported by the randomly selected clinicians involved in the care of the surgical case during the perioperative period through the CONIS, a comprehensive, open-ended non-routine event service. The non-routine event data is used to calculate the frequency of non-routine events reported by a clinician per case. The EHR data is used to learn perioperative care structure. Based on the clinician EHR interactions, we'll use network analysis to create clinician interactions. Also, the EHR data is used to capture confounding factors, such as clinician roles, patient gestational age, ventilator use, emergency care weight, and the number of procedures received. Here are summary statistics of patient and clinician information. So there are 295 clinicians reported non-routine events, and the distribution of these clinicians is listed in the table. For patients, our study contains different types of patients ranging from extreme prematurity to full term. So how to create a connection between two clinicians? We assume if two clinicians perform actions to EHR of the same patient, during the perioperative period, starting from 1 day before the surgery to 1 day after the surgery. Then there will be an edge between them. Otherwise, there's no edge. So we will create a single network of clinicians. The network includes all clinicians in the investigated 26 months. And the total number of clinicians we have in this study is 539. This includes those 295 who reported non-routine events. For the network, we investigated 3 sociometric factors: degree, betweenness, and eigenvector centrality. Here are some examples to illustrate the 3 metrics. So degree is defined as the total number of the connections from this node to other nodes. Betweenness is defined as the number of times this node lying on the shortest part between any other 2 nodes. So a node with high betweenness centrality is node like a breaker or bottleneck. Eigenvector centrality is to show the importance of a node in the network. Usually it is a hub, and this hub also connected to other hubs. Here is a network of perioperative clinicians. It made out of various roles, including NICU nurse, nurse practitioner, neonatology attending, respiratory therapist. The network has a clear communication structure, so each sub-community is a multi-disciplinary team. We learn values of degree, betweenness, and eigenvector centrality for each of the nodes in the network. Here are results show the relationship between number of patients managed by a clinician and the 3 sociometric factors. From the figure, we can see there is no association between number of patients managed and the value of the 3 factors. The reason we conducted this analysis is because we showed the 3 social factors may be related to the number of patients managed. For instance, if a clinician managed many more patients, then they will have a higher chance to appear in the networks, and thus has a higher degree betweenness and eigenvector centrality. We used Spearman rank correlation and proportion odds model to test association between sociometric factor and non-routine event reporting frequency. Our results show the frequency of non-routine events is associated with the sociometric factor values. So the frequency of non-routine events is defined as number of non-routine events per surgical case reported by a clinician. The graph shows the difference is in number of non-routine events reported per case per clinician between groups of clinicians who have higher degree and lower degree. From the graph, we can see clinicians with higher degree tend to report many more non-routine events per surgical case. We also show the distributions of confounding factors between high and low degree groups. From the graphs, we can see the 2 groups show similar distributions of confounding factors. Non-routine events play a more important role in prospective patient safety research compared with patient safety events managed by patient safety network. Because non-routine events are precursors to adverse events, they provide opportunity to prevent potential harm to patients. So our study provides evidence to develop strategies to improve clinician awareness of non-routine events. We found clinicians with high degree betweenness and eigenvector centrality tend to have high awareness of non-routine events. So healthcare organizations may promote frequent collaboration, communication among healthcare professionals. However, non-routine event collection and analysis is very challenging. So we manually collect collecting non-routine events. This is very expensive. So the an efficient way would be to develop AI or computer AI models to collect AI non-routine event or detect non-routine event in an automated way. Also, in the literature, there's a lack of non-routine event taxonomy or ontology. So we need that taxonomy or ontology to formalize non-routine events. In the modern healthcare system, healthcare professionals frequently use health information system like the electronic health record system. So non-routine events should also include health IT utilization. I'm going to take your questions. Thank you.